Now, next we come to is the heart and lung, which is the most important medical emergencies where we normally get confused whether it is a cardiac emergency or it's a respiratory emergency. So I'll just try to make it short. Now, congenital cardiac deformities may be present in the first hours of days to few weeks of life. That we all know because of the PDAs which are kept which are open and that keeps the baby alive. Prompt recognition of a cardiac etiology is imperative as management from cardiogenic shock differs from the management of other newborn shocks. Now, let's come with the cardiac symptoms. So, normally neonates which are there coming to the emergencies with non-specific findings are tachypnea, cyanosis, they may be lethargic, they may be pale, they may be sweating with feet. These are the normal complaints of our baby. And on findings, you can go ahead to find some murmurs, hypertension, abnormal pulses, and syncope. Now, we know that the babies can have congenital heart disease, which can present to us in an emergency. So neonates with the congenital heart disease normally rely on a patent ductus arteriosus and patent foramen oval to sustain their life for a few weeks. Now, unfortunately for these neonates, both these passages begin to close following after birth. The ductus normally closes by 72 hours and the foramen oval normally closes by 3 months. Now, how do we classify the congenital heart disease? Basically, normally, which if I say we normally have kept it as a pink baby, a blue baby, and a gray baby. So I'll discuss with pink baby, which are basically left to right shunt, where there is no mixing of blood, as the name suggests. Blue baby, right to left shunt, where the mixing of blood is there. Gray baby, left ventricular outflow tract obstruction. Now, how does a pink baby present to us? Now, they can cause signs of CHF and pulmonary hypertension. This leads to RV enlargement, RV failure, and cor pulmonale. The baby normally presents with signs of CHF and respiratory distress, and they are not typically cyanotic. Okay, now how will depend is basically a non-cyanotic infant in respiratory distress, crackles, widely fed second heart sound, elevated JVP and cor pulmonale. Get an X-ray done if you find that there are increased pulmonary vasculatures and RV or RA enlargement is there. Think about a left to right shunt congenital heart disease. Now, a blue baby, right to left shunt, they can cause hypoxia and central cyanosis. Neither hypoxia nor cyanosis tend to improve with 100% oxygen. And this may include tetralogy of Fallot or TGAs. Now, characteristics of a cyanotic heart lesions. Now, I'll just give a small introduction. The cyanotic heart disease, basically what we find as an emergency are truncus arteriosus, transposition of great arteries, tricuspid atrasias, tetralogy of Fallot, and TAPVC. Now, in such cases, I'm not going to go in the details, but the diagnosis which you will make, if the baby, like I told you the signs, I'll just show the signs first of all. See, get an echo done, get an X-ray chest done, and the most important thing, if you can get a CT angiogram done. Now, if you find an egg on a string appearance on a X-ray chest, you should think about a transposition of great arteries. Now, the management overall in a cyanotic case is give a CPR support, a diuretic therapy, and a surgical intervention if it's a truncus arteriosus. And to keep the patency of patent foramen oval or PDA, you have to start with prostaglandin E1 and then go ahead with a surgical intervention if and when required. In cases of tetralogy of Fallot, 100% oxygen, morphine, vasopressor support, and surgical intervention is required. Now, we come to non-cyanotic heart disease. Now, the presentations of non-cyanotic heart disease is that the cool bilateral extremities, decreased pulses in the bilateral lower extremities, decreased blood pressures in bilateral lower extremities. So there are signs of heart failure and fluid overload of the lungs. Now, how we diagnose? The same thing, go with an echocardiogram, the CT angiogram, and the X-ray chest to rule out the cardiomegaly. I discussed earlier the management is hemodynamic support and prostaglandin E1, and the final repair will be the surgical repair. Now, most important thing which you have to understand, a child with a congenital heart disease, how will he present? Now, there will be tachycardia, which will be more than 160 breaths per minute. The poor feeding and difficult feeding will be there. There will be cyanosis. There will be MSS. A poor weight gain. A child who was 3 kgs and has lost weight for the first 7 to 10 days will not gain weight even after 20-25 days, and the baby may be losing weight. Maternal diabetes, if we have a history of maternal diabetes, maternal hypertension and maternal medications, they go more towards a child coming in an emergency with all these symptoms to go into congenital heart disease. Now, what are the vital sign abnormalities? You will have bradycardia or a tachycardia, hypoxia, tachypnea, bradypnea, hypertension and hypotension. What physical findings you will find? A child may land up in shock. You will be decreased central and peripheral pulses, poor perfusion, increased work of breathing, murmur, lethargy, hepatomegaly, and crackles on lung auscultation. Now, whenever the baby presents with a suspected congenital heart disease, if you are suspecting, what you have to assess is the infant color and central pulses. So you have to measure the 4 extremity blood pressures and a pulse oximeter. The X-ray should be obtained to assess the cardiac size. Get an ECG done for rhythm disturbances, echocardiography, blood gases to never know whether it is metabolic or respiratory attenuosis, and maternal and parental history, which we had already discussed. Now, we have to understand, if you find a blue baby, you have to check for the femoral pulses. If the femoral pulses are there, check for a murmur. If you find there is a murmur, then you have to look into TOF, TA, PA, or PS. Now, if you find that the femoral pulses are very well felt, but there is no murmur, then you have to suspect TGA, persistent pulmonary hypertension, and TAPVC. Now, if you find a baby is absolutely pink, but the femoral pulses are not felt, immediately think about coarctation of aorta and aortic stenosis, severe aortic stenosis. And if you find that the baby is pink, but the femoral pulses are felt, then you can go ahead to find VSDs, ASD, and aortic stenosis. Now, let's come to a point which is very important, at least in the emergencies, is the hyperoxia test. So this test normally distinguishes whether the baby who has come with cyanosis, respiratory distress, intercostal retractions, all of the signs which confuse us from a baby to be diagnosed as a cardiac anomaly or respiratory anomaly, just go ahead with the hyperoxia test, which is get an initial ABG on room air, then repeat an ABG after 10 to 15 minutes at 100% oxygen. Cyanotic heart disease, the PaO2 will not increase significantly. If the PaO2 rises above 150 mm of Hg, cardiac diseases can be ruled out immediately. Now, if there is a failure of PaO2 rise beyond 150 mm of Hg, it suggests a cyanotic cardiac heart disease. Now, how do we treat cardiac emergencies? Now, supplement oxygen, as we have already discussed, hemodynamic support with fluids as a bolus, and then go ahead to give inotropes and chronotropes support as clinically indicated. Now, the degree of fluid resuscitation is dependent upon the underlying cardiac effect. Prostaglandins should be initiated to delay the closure of ductus arteriosus, like I had already discussed, if it's a shunt-dependent defect. Now, initial dose of prostaglandin is 0.05 microgram per kilogram per minute, and initiate inhaled nitric oxide if you find there is a sign of a persistent pulmonary hypertension. And a cardiology consultation, of course, that has to be done. Now, what is prostaglandin E1? We have to understand it promotes ductus arteriosus patency. Use an infusion at 0.05 to 0.1 microgram per kilogram per minute. A response should be seen within 15 minutes. If it is not, the response is not there, then you can double the dose and push it. If effective, try having the dose made to half. Now, the side effects with all the medications are there. So whenever you are giving prostaglandin, so I have seen cases of landing up into apnea, sudden apneas and flushing as a reaction. So please be ready with the intubation trolley whenever you are giving prostaglandin.